Hello, everybody. This is Ghassan Abou-Alfa from Memorial Sloan Kettering Cancer Center. It's a great delight to join in the Research to Practice Year in Review level webinar. We all look forward to that. And this year, I'm interested on giving you an update on hepatocellular carcinoma. So I'll start by a important paper from last year, 2022, by Dr. Maria Rieg from the BCLC group in Barcelona. Historically, if you recall, the Barcelona group has been keen on developing some staging system for liver cancer, but not only staging, but also with the applied therapy. And there was a lot of kind of back and forth in regard to that staging system, because on one hand, everybody felt that it does very well when it kind of looked at in early stage disease. That's why we say always BCLC does very well to the extreme left in regard to small disease, good liver function, take it out. A small disease, bad liver function, transplant. And then things become a little bit more kind of unclear when it comes to the intermediate stage, locally advanced disease, as well as metastatic disease. So in this effort, Dr. Rieg, for the first time, delineated a further details in regard to the locally advanced disease. And as you can see now in the BCLCB, which is right in the center of the slide in front of you, you'll see like a triforks coming down, where you can tell that based on the extent of disease, based on the ability to really bring in a patient back to transplant or still apply chemoembolization, but more importantly, yes, in some patients with locally advanced disease, maybe systemic therapy will fare better than the local therapy. And it's nice to see this kind of like multidisciplinary approach evolving and really fitting in very well in the BCLC criteria. I strongly encourage that we look at that article, because it will be very good guidance, not only for staging purposes, but also for our ability to really find what's the right therapy for every patient. From there on, it's going to be a little bit of a potpourri today. I have like collected a lot of information, and this actually is amazing that we have so much going on in regard to HCC. Usually, historically, 20 years ago, it will be probably 1 or 2 slides, and now look how much we have. So if anything, we're delighted to see a update on the Ambrave 150. This is from Dr. Ali Cheng and colleagues, and you can see after 1 year, still this study is holding very robustly. As you can see, the atezolizumab plus bevacizumab still showing an impressive improvement in survival compared to sorafenib. And at the same time, we can see that the progression-free survival, again, is showing some separation. Not necessarily to the extent that we would like it to, but it's not that big deal, because as we all know, the impact of the checkpoint inhibitors is mainly driven by overall survival, and especially more into time. And that's why to see that after 1 year, 12 months, we still have the analysis still holding and showing an advantage for the atezolizumab plus bevacizumab is definitely delightful. And we know that this is definitely therapy that works. While we're on the Ambrave, yes, there is a 050 or the Ambrave 50. This one, as you can see, I'm really dependent on a press release, but it's an exciting press release that just was reported beginning of the year. And it shows that the phase 3 trial looking at atezolizumab plus bevacizumab is an adjuvant therapy for patients with HCC at high risk of recurrence by the size and number of cancerous lesions showed, according to the outcome, even though overall survival was immature at the time of interim, but follow-up in the next analysis will probably be showing us some further update. If anything, these are kind of, coming to when we hear a press release, we know that's going to come to fruition in no time. So we all look very much forward to really see the exact details of that study. And as you can see here in the press release, yes, they are talking to the FDA, they are talking to the MBA, which tells us that hopefully things are going in the right direction. That's going to be a great awakening for us to look into the first time use of checkpoint inhibitors as adjuvant therapy in HCC. It has mechanistically and biologically a very important impact, because we are trying to really imply here, not anymore just trying to kill disease per se, but actually we're trying to set up a stage for the immune microenvironment to really not enhance any further growth or recurrence of the cancer. So we all very much look forward to see the data, and hopefully at our next meeting, we'll be able to tell things.
So if I could just ask, I know, of course, we need to see the data, as you say, but just to speculate a little bit, I actually was thinking a little bit about when you presented the BCLC classification, You were mentioning that oncologists generally don't deal that much with the left side, but it looks like they're going to be very much involved with the left side. Anything that of course we want to see the data, but any issues that you see right up front that might be informative to medical oncologists? I assume these are not transplant patients, correct?
Correct.
So do you think it is going to change the way localized disease is going to be managed? What are the do you think oncologists are seeing these patients now? Are there a lot of patients in sort of the adjuvant situation? Assuming this is a positive trial that people want to act on, how do you see it actually getting actualized in practice? Are these cases typically presented in interdisciplinary meetings that oncologists attend? How do you see this sort of being worked into clinical practice, particularly with community-based oncologists?
Well, the advent of adjuvant therapy, especially in checkpoint inhibitor setting, can be really perceived from two directions. On one hand, from the medical oncologist standpoint, exactly as you said, Dr. Love, it means that we're going to have a seat on the table, because no doubt that our involvement, our engagement will be very valuable for that purpose. However, the question is, how many patients are those? And that's really the other part of the discussion, because interestingly, surgery in certain areas in the world is perceived as being like the go-to reference point in regard to therapy. For example, in Hong Kong, this is really what mostly they do. And to be fair, because mainly disease is not cirrhotic, because hepatitis B does not cause cirrhosis and can lead to HCC, and that's why there's quite a bit of robust surgery interventions. On the other hand, there's always a claim for more transplant, and exactly your point is well noted, is that like, is this applicable to transplant? No, it's not, because we don't like to do checkpoint inhibitors in patients who are transplanted. Definitely not a good idea, and please don't do that, because it can really, God forbid, hurt or kill people. But on the other hand, will this change the perception in regard to surgery versus transplant, i.e., no doubt that getting to a surgical intervention is way faster than waiting for a transplant, and as such, with an adjuvant therapy, could it be that will be more inviting for the surgical intervention? Of course, it all depends on the data, but you're right. I can definitely envision already there will be a lot of mobilization in regard to how we understand the disease and how it will be perceived in regard to what are the curative intent that are available and how they will apply ultimately with the advent of adjuvant therapy.
Yeah, definitely the impact is going to be important. I mean, I always, usually when I see press releases, I assume it's not going to be some kind of home run or, really gigantic hazard rate, but it could surprise us. Maybe it will be a very profound effect, even if it's only progression-free survival, and maybe that will affect how people approach primary therapy. Any other thoughts about how this is going to play out in clinical practice?
Yeah, no, actually, there are 2 points here. Number one, I 100% agree with you. And please, this is a good, important message for all our dear colleagues. Press release are press release. They are like media. They are not really a medical report, and we should not depend on those for kind of making conclusion. And because you're right, we don't know really what's there, and there's an intent for that. It's not like really we're saying right or wrong, but us as medical physicians, we have to make sure we understand and look for data and analyze the data to see what it means, what implies per se. Now, interesting, you bring in like how this is going to play a role. Of course, it's going to major role, because number one, it depends on like how much of a impact it has. If it was really a home run, that's going to really change a lot of things in regard to the perception of therapy. And if such, you can envision already that new adjuvant approach will be probably playing a role over here. And as such, it becomes really a very much checkpoint inhibitor driven disease per se. On the other hand, if it's really subtle, it might kind of probably, invite us to say, maybe after all, this is not really the right approach per se. I think we just have to wait and see. Biologically, it does make sense. The immune microenvironment is definitely very much driving this cancer. And I would say it will have implication way beyond that. Because, for example, in the Western Hemisphere, when we resect, and our colleagues in surgery will resect a tumor, they will just circle around it, make sure that we have a negative margin, and they take it out. Interestingly, in Japan, they don't do it that way. They will actually cut the whole segment in the liver, because they think that this is a segment that's infected with the tumor. And you can imagine the philosophy of the disease can be really delineated further by what the results are going to be in that regard. So yeah, go ahead.
I was just going to say, I don't know, are there any efforts to actually use neoadjuvant systemic therapy, for example, in Japan, to make people resectable?
Not yet. And we have to really make sure that we pinpoint here very important differentiation. Making a patient resectable, it means that we're not doing new adjuvant, we're doing conversion therapy, changing non-resectable to resectable. We are way too far from this. On the other hand, making a tumor still is resectable, but we're making sure that it has less recurrence. This is what new adjuvant is. To be fair, we will not jump to that next step until we see the adjuvant therapy. So I think after that, and that's why we said within the impact of Ambrave 050, we'll probably see more and more of the new adjuvant approaches coming along.
Okay,
So
please
with this
continue.
said, of course, with this said, what else going on? Of course, we're delighted and we're proud of the effort that we presented regard to the Himalaya, which is looking into durvalumab plus tremelimumab versus sorafenib. This study showed an improvement in outcome, 16.4 months compared to 13.7 for sorafenib. The study also looked at durvalumab as single agent compared to sorafenib, but for non-inferiority. Totally different design over here, 16.56 versus 13.7. The study is positive clinically and statistically. And always people ask the question, and they say, well, wait a minute, why should I really use the Tremi if Durva is already giving me good results per se? Well, yes and no, because as we see, the Tremi is given as only one dose only in patient's lifetime. That's quite impressive because you're priming the anti-CTLA-4 activity to let the Durva work better as the anti-PD-L1. And as you can see, the translation to that is that on the combination of what you call in blue the stride, which is Durva Tremi, you can see that about 1/3 of patients were alive at 3 years. We never seen those numbers. Now, the second question that we are asked is, oh, wait a minute, are you trying to convince us about this 16.43 months? Already I heard about something called Ambrave 150 with atezolizumab for 19.2 months. Well, here's an important basic biology, a basic science, a basic oncology question. We can't compare if the demographics are not the same. And if you look very carefully, you'll notice that in the Ambrave 150, about 50+% of the patients were actually hepatitis B, while here in the Himalaya, it was only about 30%. And we know very well that in all studies, regardless who they are, patients with hepatitis B will fare best in regard to checkpoint inhibitors, followed by Hep C, followed by the non-viral. Everybody will benefit, but not to the same magnitude. What's important is there was a study done in the UK recently called the REAL AB study, Real Atezolizumab Bevacizumab study. And they found actually mean survival for the Atezolizumab Bevacizumab was 15.73. Interestingly, if you look at the data, the amount or the number of patients with hepatitis B were way less than it is in the Ambrave 150. If you were to ask me what's going on here, I think they're all okay. I mean, atezolizumab, durvalumab are all equal. It all depends. If you were to do the Himalaya again in hepatitis B patients only, guess what? You're going to get a way higher median survival. If you repeat the Ambrave 150 in hepatitis B patients, it's going to be way lower, etc. So I think all of this is just that are all beneficial therapies, and then choices can really be brought in regard to many other variables.
What about tolerability and toxicity? Of course, you have the issue of the anti-CTLA-4, but as you said, it's only one dose. It looks like the incidence of complications is much less than Ipi-Nivo, for example. How would you indirectly compare, including your own personal experience? You probably have as much experience as anybody with this stride regimen. How would you compare tolerability indirectly, atezo-bev versus durva-tremi?
Well, I would say, Neil, this is a highly tolerable regimen. You recall we spoke about that at the time we presented it back in 2022 at GI ASCO, and a lot of hands-on experience so far, and it's really no sweat regimen. Imagine you give the two therapies together, and then you don't see the patient except once every month for the durvalumab. And thankfully, the adverse events has been super minimal. The interventions really that you need for that purpose are really very minimal as well. So I would say for convenience, practicality, the durvalumab has been really pretty straightforward. And also on top of that, to talk about toxicity, remember, we don't have a concern for any bleeding over here. So the use of any endoscopies to rule out varices is not needed. Actually, we didn't even do it on the study. There was no bleeding reported from that varices study and varices from that trial as well. So all in all, durvalumab is very straightforward. Actually, the joke is that we have to convince patients to come every month to come to their therapy because they're doing great.
Awesome. Please continue.
Great. So to jump on, and this is very important. Now we have a bunch of data that jump on to us from the ESMO in Paris last September, and among which is the tislelizumab, which is again one more time a anti-PD-1 therapy, which was looked as single agent compared to sorafenib. And as you can see over here, there was non-inferiority. It was 15.9 months for the tislelizumab versus sorafenib 14.1 months. Interestingly, it shows exactly what already we know, that a single agent anti-PD-1, anti-PD-L1 will not fare any better or any different from TK1, from tyrosine kinase inhibitors. And this study proved it one more time that this is really correct as well. What will be the role of tislelizumab in our kind of regimen? We're not sure. Actually, there is a certain particularity, and I here disclose that I was involved and chaired efforts of the clinical trial, but nonetheless, those variations in regard to the enhancement of the activity did not necessarily fare any difference in regard to outcome. I think still we are in the same realm of anti-PD-1, anti-PD-1, good outcome, but not necessarily different from any other. But it will be nice to see if this will be providing more accessibility to therapy worldwide as we need more interventions that are necessary for that.
I'm kind of curious right now, in what situations, if any, will you use first-line single-agent IO, and which agent?
Yeah, single agent IO as a first-line therapy, it's kind of like the best I can see is like a certain relative discomfort with using the tremelimumab in combination with the durvalumab. And as you said already, Neil, the diarrhea has not been an issue at all in regard to the one dose of tremelimumab, contrary to what we have seen with EP. So I would say seeing less and less of those, except if accessibility issue or at the same time a certain relative concern. But otherwise, a durvalumab is a totally appropriate option. So with this said, this is very important awakening for us. This is now published. Give great credit to our dear colleague, Dr. Katie Gary, that looked into combination of cabozantinib, the anti-CMET, anti-AXL, anti-VEGF that we know, plus atezolizumab versus sorafenib. That study, interestingly, was negative. As you can see, it has no improvement in regard to the PFS and no improvement to survival as well. Now, two important thoughts about that. Number one, mechanistically, we know very well that the CMET is kind of like a pathway which is almost a little bit to the extreme of the cellular pathway from the cell membrane to the nucleus. And as such, probably the intervention of the cabozantinib in regard to the cell immunity cycle is not necessarily there. And number two is my personal opinion is the primary point being the PFS was not necessarily the right one. This should have been an OS study, not necessarily that, but we're seeing the results of the OS, which was negative, which go back to the biology per se. And the reason I say that is because these tumors, they get primed by the immune therapy. It takes a while until they get their effect. And that's why the OS will kind of like over time will kind of show their effect. Interestingly, what we heard and learned about the chemotherapeutic intervention with the median survival as being our reference point, yes, it makes sense. You kill half of the cells, you kill, you know, it implies that half of the patients are alive. That's totally fine. But interestingly, when it comes to checkpoint inhibitors, it's not necessarily that. It's actually take a while until you prime and mature the effect of the checkpoint inhibitors. And that's why I kind of jokingly always say is that we're using an old dictionary for a new language. And this is really what's important to really remember about the cabozantinib plus atezolizumab.
So I'm not exactly clear. Are you saying this is a negative study?
Yeah, this was a negative study, and as we know, it did not carry any further. And as we can see here, the survival was negative, and the PFS was subtle difference. You can say hazard ratio was 0.63, but not enough to really to prove that there was a benefit over here, the one that we're aspiring for, got to other combination of the checkpoint inhibitors plus the TKIs. So to carry on, and again, as we said, the potpourri, this is another negative study. This came lost as a big surprise, the LEAP-002 study. Great credit to our dear colleague, Richard Fenn, for presenting this at the ESMO in Paris last September. Combination of lenvatinib plus pembrolizumab compared to lenvatinib plus placebo. And it was negative. As you can see here, the median survival for the pembrolizumab plus lenvatinib was 21.2 months. And shockingly and surprisingly, the median survival for lenvatinib plus placebo was 19 months. Now, here there are a lot of thoughts. And to be fair, we don't really have yet all the data because this is still in the setting of a abstract form. There's way more details to kind of follow, even though it was reported at the meeting that about a quarter of patients in the lenvatinib placebo did get as second-line checkpoint inhibitors. On the other hand, we know that the FGF might have value in regard to being a driver for the checkpoint inhibitors. And interestingly, would it work better in sequence rather than in combination? We're not sure yet. And as such, we are kind of like always reflecting on that study by saying this is the most positive negative study ever, because if anything, it was negative study in regard to outcome, but on the other hand, it is really showing a quite positive outcome of the lenvatinib as 19.0 months, which is way higher than we're seeing with other TKIs, including lenvatinib itself. So this is food for thought. We have to wait until more data come out so we can understand better what it means per se. And of course, it will probably make us revisit if sequence or combination is really the right way to go. This is like really things that we are really did not really vet out first. Everyone wants to be in the front seat of the bus. All those studies do look into combination therapy as first-line therapy. But is it biologically the right thing to do or not? We're not really sure. So we have to wait for more data in that regard. This is relatively new, and this is actually looking into the atezolizumab plus bevacizumab versus lenvatinib or sorafenib. That looks at the propensity score matching in a quasi-experimental way to really match the patients that are with similar characteristic into the treatment per se. And you can see over here clearly that always the outcome of the atezolizumab plus bevacizumab really did not necessarily show an improvement per se. We can see that lenvatinib stood out in most of the time. And this, again, one more time, a good opportunity for us to really reflect further on the issue of the sequencing of therapy rather than the combination per se. This is still something that we really don't have a full hands on, but it definitely gives an invitation for a carry on to what I just mentioned a second ago. Now, this is one that is regard to the CHARPU score. And over here, nice work that, again, I was a senior author on with Dr. Koueri, looking into cabozantinib in patients with CHARPU. And you can see, very important here, that yes, patients did still well on that therapy, 8.5 months compared to placebo 3.8. And more importantly, we can see that the CHARPU was not only B7, which usually is kind of like where we think it's like, it's like an A6. As you can see, we had an appropriate number of patients with B8 and B9. And if anything, it's an invitation that after all, tyrosine kinase inhibitors probably will fare well in regard to patients with CHARPU B. I think the most robust data is still come from sorafenib that was studied extensively beforehand, the part of an alliance study, and where we showed that actually a dose adjustment of the dosing based on albumin bilirubin level can be beneficial for adjustment of the therapy. And here cabozantinib is at least suggesting something of that same nature that could be visited further. This is becoming very important, the CHARPU-B story, and maybe we're showing cabozantinib data, but of course, even our comfort zone regard to use checkpoint inhibitors in regard to CHARPU-B is evolving more towards the better and better. And I would say, and I hope that we'll have at least a safety assessment clinical trial to really show us that, yes, it's safe, or any adjustment that needs to be done in that regard. One more effort that, again, I was heavily involved in regard to the cabozantinib and the quality of life. This was reported relatively newly as well. And you can see that really what quality of life is dependent on many dimensions, among which the critical one is mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. It's a very important 5 components that you can see over here. And thankfully, the cabozantinib, no doubt that maybe there was a teeny mini dip in the beginning in regard to the benefit, but ultimately everybody did fare better on the therapy per se. And this is very important to relate to our patients that after all, any intervention is better than no intervention nowadays, because we have seen that besides some side effects that ultimately can be adjusted for or be tolerated, will probably be a benefit for the patients, like in the cabozantinib over here. So again, to go back to the checkpoint inhibitors, and as I said, this is a potpourri on things, but this is an interesting arm of the pembrolizumab, but this time is in Asia. And remember, in Asia, what do we have? We have patients with hepatitis B. And over here, we can see that there was a clear improvement in outcome. We can see clearly that here the hazard ratio is in favor of the pembrolizumab. And if anything, it tells us one more time, at least, an invitation that a checkpoint inhibitor in patients with hepatitis B will fare very well compared to the patients without hepatitis B. Actually, there was different iteration of that same data here. This time is presented by Professor Shen from Nanjing, but there has been actually looked into this part of the study of pembrolizumab versus placebo in second line. Also, it has been looked separately in this trial from Asia. Now, to go back to the discussion that we spoke about a second ago in regard to the IPI, this is, if you recall from the CD40 study, like a very, very robust clinical trial that really went on in multiple variables. We can see over here that a 5 years follow-up of the Nivo 1 milligram per kilo plus IPI 3 milligram per kilo given every 3 weeks for 4 doses, followed by Nivo as single agent every other week, is continuing to show that the Nivo IPI, Nivo 1 IPI 3 arm, which you can see on top in the light red, is continuing to fare very well. This is, of course, within the context of being a phase 2 study. We cannot conclude more than that. But of course, we're all waiting for the phase 3 clinical trial that will tell us if really the Nivo 1 IPI 3 will remain as a option of therapy, which is at the moment only have a conditional approval in second line, awaiting, and because of the CD40 was like in second line, awaiting for the phase 3 clinical trial in first line. So we just have to wait and see. But again, as Dr. Love mentioned, maybe the IPI 3 times 4 has been rather not an easy walk in the park compared to the TREMI that we have seen without necessarily that much of adverse events. Quite exciting continued information here. And now we're really bringing another perspective here in regard to the Nivo IPI, but this time with the cabozantinib on board as well. So Nivo cabozantinib plus minus IPI. And this data was reported very recently by Dr. Thomas Yao and colleague from the CD40 study. This was in arm, I think it's called arm 7 or arm 9 on this study. And you can see clearly over here that the Nivo IPI plus the cabo rather fared very well in regard to the progression-free survival. In regard to us, not that much, but again, within the context of phase 3 clinical trial, at least is an invitation among many others that we're seeing that looked into combination of double checkpoint inhibitors plus a TKI, and we'll see where this is going to fare ultimately once hopefully we'll see the Nivo IPI study results per se. So as you can see, and not to confuse everybody, this is becoming way too complex of different potpourri of different options per therapy. But I think we have to stick to the data. And at the moment, regard to first line, the options remain. And to remind everybody, the atezolizumab, durvalumab, and sorafenib or lenvatinib as single agent therapy. That's pretty much it so far. However, there's also data on the pembrolizumab plus rivoceranib versus sorafenib study that was done in China. Again, Professor Shem presented that at ESMO in Paris last September. Positive study. Look at the median survival, 22.1 months compared to 15.2 for sorafenib. Why is that? Because again, one more time, remember, patients have Hep B. Actually, in that study, about 70% of the patients were Hep B, and still with a great positive results. I would not be surprised that this combination will kind of push forward, and we might see even some receptiveness to really consider it in the Western Hemisphere. We'll just have to wait and see how it settles in regard to the agencies and in regard to the final paper. But that's quite interesting and very valuable different combination of therapy of an anti-VEGF plus anti-PD-1. Now, to kind of like change taste from this, because again, one more time, after we spoke about all those studies, I would like to really revisit one more time the following. After all, we're all excited, great results, great data, but who has access? And so in an effort that we did that was reported part of the aortic meeting back in Senegal in 2021, we actually interviewed 500 physicians mostly from Africa, where, by the way, it has the highest incidence of liver cancer in the world. And guess what? In north-south of Africa, where the two highest GDP are being Egypt and South Africa, and in east-west, where you have some of the second highest GDP, including Nigeria and Ghana, and Tanzania on the east, and then central, which is mostly the central countries, including Chad, Cameroon, and Malawi. And as you can see, that sadly, so far, even in the highest GDP, 84% of the physicians only have access to sorafenib. That's it. And as such, this is an obligation on our part. We're excited. These are very expensive efforts. They are very valuable efforts, but can we really claim one day that we're reaching out to everybody and present that those options of therapy? This is really where the success will be, rather than kind of like confine it only to the patient that has access, which ironically will be the limited number of patients compared to what's really the high preponderance and high incidence of the disease in other parts of the Asia, especially in sub-Saharan and also in the Egypt, add to the Southeast Asia per se. I already spoke about that, but just to bring it in a slide format and to reiterate it, that after all, atezolizumab still positive study, but real world data is 15.74 months, not that similar from the 16.43 of the durvalumab. And if anything, it become more of a convenience for any of you in regard to use one or the other. As Dr. Love asked, like, yes, of course, the atezolizumab is a great positive results. No question that probably about 16 months, all of them, but endoscopy is critical. Make sure you do the endoscopy. Don't really say, okay, I don't think patient has varices. Please make sure you do an endoscopy. And on the other hand, the durvalumab does not need an endoscopy and the convenience of once a month therapy. And lastly, I would just bring in a clinical trial only because really, again, to think same way we looked at the adjuvant therapy. In local therapy, yes, can we combine those therapies together? Yes, we can. And this is a clinical trial that we proudly are leading all over the world, it's the Emerald 3, looking this time into chemoembolization versus chemoembolization plus durvalumab versus chemoembolization versus plus durvalumab and lenvatinib. TKI, checkpoint inhibitors, and local therapy versus checkpoint inhibitors plus local therapy versus checkpoint inhibitors. As you can see, we're obligated to do all of this. This is an important one, not because we're just like to add things together, because biologically, the lymphocyte neutrophil ratio will be affected so much by the embolization, and no question the immune microenvironment will probably be enhanced to permit probably some value for the use of the checkpoint inhibitors. So I kind of I warned everybody it's a potpourri of details, but quite excited to see that much happening in 1 year in HCC, and this is only a snippet of what has been going on. But I pass it back to the chair. Thank you.
So, can I just ask about that last study? Am I correct in saying it's durva, lenvatinib in one arm?
Correct.
And I assume there's already safety data for that?
That's very true. Actually, there's already a good read on all of this, and it's not an issue at all. So we're happy with that combination. Yes.
It's just interesting to think about adding lenvatinib into durva. Are there like other trials looking at that triplet?
Not that I'm aware of, but I know that has been really a visit of the component by many different combinations per se, because at the moment we have a phase 2 study that looked into the combination in regard to the triplet, and no doubt that we're going to see more and more of those going on, because after all, it seems that having a TKI and specifically an anti-VEGF could have a lot of value in regard to the triplet combination.